So I'm the only thing standing between you and the balmy weather out there that's waiting for you to enjoy. I have to say I learned a lot the last day and a half here. It's been an incredible experience, and I really want to thank all the speakers for excellent presentations and for making so many good points in summary fashion. What I'm supposed to do in the next 10 minutes or so is tell you everything that we talked about in the last day and a half. So I'm not going to do any great justice to the speakers, nor to the individual points that they made. I do want to try and pull out a few themes and issues and ideas about where we go next and leave them for you to contemplate. I have to tell you that I'm not an expert in this area, which probably makes you wonder why I'm standing here. But I'm told fresh eyes are sometimes good, although my grandchildren remind me my eyes aren't so fresh anymore. Usually one of the things that was very nice about this meeting is we usually go to these meetings and we spend a lot of time beating ourselves up about what's wrong and what's undone and all the things that need to go forward. But you all actually started out with a little bit of a celebration of the fact that of the progress you've made since the 2006 PRG report. And that actually sort of carried through this. There seems to be some momentum that the group is feeling about where they are now based on that transition. So that was really nice to see. So that said, let me just spend a few minutes then going through some of these key points here. First of all, I want to talk just for a minute about values. One of the things that was really encouraging to me, and not terribly surprising, is that for the most part, we kept our eyes on the ball most of this meeting, and that is what's good, what's in the best interest of the patient. We talked a lot about using words like patient-focused. We talked about patient-centric. We talked about engaging patients more in their care. We talked about engaging patients more in decisions, et cetera, and the implications of that not only for their outcomes, but also perhaps for some of the research. I also like the transparency I heard repeatedly. There was this constant theme of we can do better, and you guys were pointing out the things that we can do better. The other thing that was really gratifying as well, and certainly earlier in my career I didn't see a lot of these, was these constant calls for better integration and coordination. Over and over and over again, you all kept raising issues that we've got to get the day together. We've got all these different programs going, all these one-offs. Let's look at what we can learn from each other and that eagerness to learn. And then there was always this underlying thing about keeping progress going. So I have categorized some things, lumped them. I'm a lumper, not a splitter. I categorized some things, but these are not mutually exclusive categories, and you'll see that in a moment. The first set of things I wanted to go through is who are these people that we're talking about issues? So we threw up 15 to 39 very early, and yet at the same time we began seeing some calls today just reminding us actually that some of the studies that have been done amongst people like this actually are from childhood, people who were diagnosed in childhood, not necessarily diagnosed in that 15 to 39 area. But it did raise a bunch of questions, at least in my mind, about the value, because this is such a non-homogeneous group or a heterogeneous group. We talked about differences in lifestyles. We talked about the wide range of people and where they are in their life cycle, their developmental life cycle, and the different needs that they have. We talked about the fact these are people with multiple kinds of cancers, all with different needs. We talked about the fact they come from multiple cultural areas. We also talked about the fact that this population is very dynamic. And dynamic in the sense, Archie presented some data that shows over time, certain cancers are on the rise in this group of people, other cancers are on the way down. Society's changing around these folks. We're changing. We made a lot of references today to the issues of needing to understand how to communicate with these folks and using these things, which is not here because I have a call coming. I'm timing myself. And then we also talked about the fact that medicine's changing as we go through these things. So there's a lot of things happening, a lot of transitions going on that make this population not only diverse within itself, but also a population that's being impacted by a lot of dynamics externally. Today, we also talked more about mobility and the fact that we have such a geographic spread in these groups, and that spread may be impacting the kind of care they get based on state laws and other sorts of things. We talked about the critical importance of support to these folks. We talked about the family notably. I thought it was just sort of interesting today that we saw this slide early on about what happens with the gain in weight among family members while the patient's gaining weight during treatment. Well, I guess that's sort of a negative. And then on the flip side of that, we also talked about the importance and the role of the nuclear family, perhaps in these communications conversations we have, especially at the lower age ranges within the AYA group. And then we also mentioned on a number of occasions the point that, and a number of people reminded us this cancer is always a big negative, but sometimes there's very positive things that come out of the experience, given that you've got to go through a negative thing. We spent a bit of time talking about how when people are confronted with a diagnosis in these age group, everything changes because they're not thinking of these issues at the time that they're going through them, where they're actually thinking about other things, mostly futuristic. And so a lot of hopes and dreams are altered. At the same time, we spent a lot of time yesterday talking about work and school issues and all of the issues and the relationships of those things on quality of life. We heard about expressed unmet needs among this group of people for information and services. We heard more of that today. We also talked about psychosocial impacts, including how people in these groups manage their own emotions, as well as those around them and the burden that puts on them. And we also heard today a little bit about this notion of distress and distress trajectory, which I personally found quite interesting. I want to say a couple words about disparities. In the disparities arena, we know that there are disparities in these groups, and we had some of these reported. And by disparities, I'm talking about those who are suffering unequal burden even within this group. And one of the things that I think is important in looking at this is the repeated references to the fact that we don't understand very well what those disparities are within these groups. That we tend to study the population as a whole or the group as a whole and not to look, for example, at the effect on some of our minority populations or others. And we heard the expression of that a little bit today when one of our speakers talked about the low confidence people have in managing their survivorship if they happen to come from a minority population or they didn't have a written survivorship plan. And of course, we heard few references recently to the issues of public differences in public versus privately insured folks and also insured and uninsured folks. So now I want to flip a little bit to the research issues for just a moment. One of the things I heard yesterday and seemed to be repeated on a couple of occasions in different ways is the research in this area is currently a field in transition. We seem to be moving away from just epidemiological and observational studies, moving in the direction more so of intervention studies, and of course, ultimately formalizing education, training, and standards. So a whole host of needs, research needs, which I'm not going to go through one by one, but I did want to pick on a couple here, came out, and one of those was the need to outline research priorities. We also talked about the need to have better tools, and we talked about service delivery gaps. We had a reference today to this notion of reversing the disparity in survival progress and all the issues associated with that. We talked about researching different care delivery models related to this particular population. We talked about clinical trial accrual. I was a little bit struck today that the 14% accrual, I think that was the figure that was used, 14% accrual in this particular population, in the AYA population, compared to the accrual in the childhood cancer population, is a huge drop-off, obviously. On the other hand, I spent most of my time on the other side of the fence thinking about the 3 to 4% accrual generally, so they look pretty good to me, but the point is there is a drop-off, and there are structural reasons why that happens, and we ought to be thinking about those structural reasons and looking at ways to impact on them. There were calls yesterday and today about evaluating outcomes and impact and the importance of having some concrete examples for meaningful outcomes, meaningful changes that have been made. This is both an issue for getting funding, it's an issue for changing policy, et cetera, and I think that was one of the major points that was made. And a call also to have some urgency about better understanding and managing late effects. I got a little confused, and I'll admit that throughout this, because I heard two different stories about guidelines. One is we have guidelines and we need to better adhere to them, and the other is we have a paucity of guidelines. I think, and you can correct me afterwards if you'd like, that this may be a distinction between general guidelines about survivorship among the group and those specific guidelines about things like follow-up, by cancers for individual, follow-up for individual survivors with individual cancers. We need better information on the AYA population. One of the things that was said is maybe we ought to start not just looking at them by the blocks of age groups within that broad 15 to 39 age, but also perhaps now starting to drill down and look at them by cancer and even by treatment within cancers in terms of trying to do some of the studies we do. We also talked about increasing the use of existing data. And this morning we talked about the fact that there is some confusion in the data. And how can we best address that confusion? If we have some studies saying the data is all over here and other studies saying it's over here, then somehow we have to reach agreement on what does that really mean to us. And we talked about research on networks that are servicing AYAs, social networks that are servicing AYAs, and also the importance of perhaps starting to look at alternative research methods. All the issues we had around the quality of the surveys, their different biases and limitations and so on and so forth, yesterday really suggests we should be looking at ways in which we can codify perhaps some other methods of collecting data. There's a whole host of information on practice issues that were in front of us. And I'm not going to go into all of the different ones. We certainly talked a lot about access issues, and I already mentioned just a few moments ago about the insurance side of that. I want to say just a brief word about the issues around the ACA. Archie made sort of an impassioned plea yesterday that we recognize it's in trouble, and we need to be speaking out on these issues, which I would agree with. At the same time, we have low public knowledge of what's in the ACA. People don't understand still what's there, and shame on us for not doing a better, us as a collective community, for not doing a better job of making that happen. And the number of don't knows on some of the slides that were shown towards the end relative to this was quite interesting to me. We briefly mentioned, by the way, I'm just as a side note, I have to tell you, there will always be repeated moves to repeal the ACA. We don't know how that will go. But I have to say the train's out of the station on some of the provisions of the ACA. Some of the things that have happened are not going to go away. There's no way the public will let them go away. Just look at the age 26 raising issue for insurance. So I don't believe it's either all, but we don't know what might happen. And given the way Congress is acting these days, that's anybody's guess. We talked about briefly, and I heard several mention of the notion of AYA specialists as emerging as an important area of consideration, and there are fellowship opportunities, et cetera, that are out there. But we didn't really speak a lot about that, and we didn't really talk a lot about some of the workforce implications. I do think this is an area that probably needs some attention going forward. There were references today, and I don't mean this critical of the conversation, about potentially primary care picking up some of these responsibilities. But I hate to say it, they got workforce issues too, and in the primary care arena. So we have to figure out how we're going to deliver on the services that we've all come to believe are important, not just in this particular instance, but others as well. Great presentation this morning on communications issues around how we can communicate with AYAs. I particularly like the references to the helpful, hurtful kinds of analyses of what helps us when we talk to these folks and what hurts us, and obviously the age and cultural relevancy issues. We also talked briefly about managing issues during survivorship, but with the exception of the fertility issue, we didn't really talk much about the actual process of survivorship planning. Sort of said it's all out there, it needs to be done, et cetera, but there are open-ended questions that were raised by folks about how we actually get these things done. The study that was done and reported on this morning about the 20 existing programs that are providing psychosocial services to the AYA population pointed out the variability in those groups, the different methods they use, and questions of sustainability were also discussed today. Certainly a wide open area to be considered. And I'm not sure, perhaps I can connect with the individual later, but I'm really not sure, was 23 the universe, or was 23 the ones we happen to try to get it in a particular way? I think that's a very important issue, because if it's 23, that says a lot by itself. We heard a lot about this idea of healthcare transition, and one of our survivors yesterday talked about the healthcare transition issues. We also talked today about not primary care, palliative care and end-of-life issues. I noted particularly this death anxiety problem that exists within this population, perhaps more so than in others, and the importance of advanced care planning. And repeated references to the coordinated care issue. And then we talked during the questioning period about this notion of looking for more and better integrated approaches to assessments. The way I want to leave the practice issue is just simply to say that the ideal, one person said it yesterday, and I like the way they said it, is to deliver developmentally informed care within this population of folks. We had a great presentation on fertility. I'm not going to go into any details just in the interest of time here, but we had a great presentation on fertility, but I did note that the timing of the discussions around fertility are critical. And if it's done at the point of diagnosis, then one of the underlying issues is what does that do in terms of timing of onset of treatment and some of the other challenges that are presented with that. I also noted in that particular area the important need we have to inform patients and then to have ready referral mechanisms if people are interested in these issues. But I also noted that it was said that we don't really have any focal point for that happening right now. So who's going to do that? When are they going to do it? And how do we challenge people to assure that happens? We had a lot of discussion about the opportunities for prevention and early detection as a result of surveillance and follow-up. I would agree with Patty entirely. There's an extraordinary opportunity here to save potential life years, a lot of potential life years. But we also need to recognize that in these groups, this is the highest group for risk recurrence, or highest group at risk for getting another cancer. And I meant to say it that way, getting another cancer of any one we've got, and yet it's the one where prevention services, we almost never talk about it. So the fact that it's being talked about here, I think, is really critical. And the fact that 16% of cancers are now second primary, it sort of says we should be paying attention to this a lot more. And I certainly know within our prevention effort, Patty, we're going to talk about this when I get back to my group. But we also talked about the fact that we have a lot of interventions that work for some of the behavioral issues that we face. There seemed to be a little bit of disagreement in the data we were getting today, which was actually pointed out nicely by one of the speakers in terms of the actual prevalence of these, but it doesn't matter. The prevalence is higher than it needs to be and should be, and we should take the opportunity essentially to intervene where we have an evidence base, a strong evidence base that we know how to do that. We need to have better uptake of those prevention services along the way. And I did note today one of the statements reminded me, I think Karen Eamons mentioned the fact that there are issues about where we get treated and where we provide services. If we provide them in academic settings versus what happens in community settings, also prompted me to think about the cancer centers. And Karen's comments this morning reminded me that if somebody ought to be leading on who's providing these services to these folks, it ought to be within our cancer centers. And so we have some work to do there as well. So the last thing I want to do is just say a couple of words. We had three very different survivors with us yesterday. They had three very different cancers. They had three very different experiences. They were obviously different people. In a sense, they're a microcosm of this whole population that we are dealing with. And so I just wanted to very quickly go over a couple of key points they made. One was made just a moment ago, but this idea of connecting with their docs and the strong affinity they felt for the people who treated them. The willingness perhaps in one case to even move to another place if the doc moved to another place is an expression of that. So these are obviously very deeply personal circumstances, very strong. But we also heard a story yesterday about how the person's doc went on vacation and the doc that replaced that person for the interim actually had no clue and didn't much care about where that patient was at. So there are issues we have about how we transition care and how we deal with folks. And while these people all made contact with and had an affinity for good care, not everybody finds that doc who has that affinity for them. A lot of discussion about coordination of care and case management. I like the fact that there was discussion yesterday among those folks about stigma they still felt about the disease, and then one impassioned plea that says, I had that stigma, I got over it, now I own my disease. Well, we're going to find all of those in the range of these folks, and how do we provide and help them with that? A lot of discussions about financial issues, the need for financial counseling, et cetera, but finances are not insignificant to these folks, and we need to figure out how better to provide those services, which sort of prompted me also to think about navigators and others who help patients, social workers and others, and what can be done to shore them up for that. Last thing I want to make, comment I want to make on is this idea of giving back that was brought up yesterday. And one person made the comment that, of course, it depends on where you are in your acceptance of your disease. If you've accepted what's happened to you, and now you're thinking about the future and where you're going from here, you're more likely to be willing to give back, and that includes participating in research. At the same time, if you're going through it and still in it, still upset about it, still angry about it, that giving back may not be there, but it may be there at some point in the future. What was interesting to me in telling, and this is my very last comment, is just to say that the person who was very willing to give back and participate in research also said to us very quickly, tell us what you're doing with the data. This is what happens in community participatory research all the time. We do studies, we walk away, and people don't hear what happened. We somehow don't get back to them. It's very important for us to take this idea up of helping people understand what we're doing when we want to do research, especially in these populations who don't have a lot of experience. So it was an awesome meeting. It was very well planned. You two deserve a lot of credit for the effort you put into that. The speakers were awesome, and I really appreciate the opportunity of being here. Thank you.